Good afternoon, everybody, and welcome to our Heart and Stroke Presents. We are very excited that this is Stroke Month, so thank you all for joining us. Today, we are very pleased to be working with our partners, the March of Dimes of Canada, and together we're presenting you this webinar called The Evolution of Virtual Care Through the Stroke Continuum. We know that the last year and a half has brought dramatic changes to how we deliver stroke care. We wanted to take this opportunity to share some of our learnings with you and hope to enhance your practice. We also welcome all the people with lived experience who are out there watching with us today. You're the reason we're here. You're an integral part of everything we do, and we're really thrilled to have you with us as well. Our moderators are myself. I'm Patrice, Lindsay. I'm the Director of Health Systems Change at the Heart and Stroke Foundation, and I'm very pleased to be working with my colleague, Christina Sperling, who's the National Director of Community Programs and After Stroke at the March of Dimes of Canada. Say hi, Christina.
Hello.
So just a couple quick things about GoToWebinar, and then we'll get right into our program. First of all, your computer, you should listen using your computer speakers, and it gives you the choice of computer versus phone, so choose computer. Attendees, you'll be muted if you join via the phone. If you have any problems with GoToWebinar, please contact tech support. We are not the techies and won't be able to help with technical things. For questions, we really want your questions. Please start entering them throughout the presentation. There's two different functions you'll see. One is chat and one is questions. Please put your questions in the questions section here, and we will answer them. If they're technical questions, they will be answered throughout, and all the content questions will get answered at the end. For those of you who like to tweet out there, please send out your comments. Hey, I'm watching this fabulous webinar. Happy Stroke Month, everybody. So you can tweet as we go. That'd be awesome. And just please include the handles for Heart and Stroke and for the March Dimes. Thank you. So this webinar is being recorded, and an archive of this will be put up on our YouTube channel within the next week or so. There will be an evaluation sent to everyone who registered at the end of the session. We really encourage you to complete the evaluation, especially now, because this is our last one of the season. We'll be starting up again in September. And one of the things we ask on your evaluation is what other topics you want to hear about. And we really want you to tell us now so we can start planning through the summer. We will be doing another joint webinar with March of Dimes sometime in the next year. And we have lots of other things we want to share with you. So please let us know what you want. Certificates of participation are available. In order to get one, you do have to complete the evaluation. Once you've completed it, there's a link at the end to get your participation certificate. Just a little reminder that today is a double header day. Tonight, starting at 7 o'clock, the Canadian Stroke Consortium is also having a webinar on PFO closure for secondary stroke prevention. This is incredibly timely because sometime in the next 72 hours, the new secondary prevention of stroke guidelines will be publicly released by the journal, and we'll let you know. You'll get an announcement as soon as those are live. We've all been very anxiously waiting, and they'll be here soon. I'm very honored to introduce you to our speakers for the day. We have three fabulous presenters. Our first speaker is Mawji. He's a person with lived experience and a March of Dimes volunteer. Dr. Anita Mountain, Assistant Professor at Dalhousie University, Division of Physical Medicine and Rehab. She's also our lead for the Canadian Stroke Best Practice Advisory Committee on the rehab and recovery side. And then representing the March of Dimes of Canada and our colleague for many years and principal investigator for the Collaboratory Research and Innovation Institute is Michelle Nelson. So you'll hear from each of them today about virtual care and about how we use it within stroke care. None of our faculty have, Anita and Haas do not have disclosures. Michelle's disclosures are here with grant support from CIHR and the Ministry of Health in Ontario. Today's objectives are to describe current landscape and challenges in stroke care, discuss opportunities in using virtual modalities for stroke across the continuum, describe how community-based organizations such as March of Dimes have pivoted their service to virtual care as a result of COVID, but so many lessons learned as we hope virtual care is here to stay. And our overall goal is to improve health outcomes through practical tips, tools, and implementation strategies that you can take back as clinicians to apply to your practice, and as people with lived experience to take back and share with your clinicians so that your care is optimized. I will now turn it over to Christina to introduce Haas.
Thank you so much, Patty, and welcome everybody. I'm so happy to be here with you today. It gives me great pleasure to introduce our first speaker. Haas is an active participant at March of Dimes with our After Stroke program. His journey post-stroke began in February of 2015, and while his career plans took a backseat to his efforts to recover from his stroke, he was able to take advantage of his interest in developing his technology skills to also improve his communication and speaking skills. Last year, when the pandemic began, he joined a national virtual conversation group and a virtual Aphasia Peer Connect program, both offered through March of Dimes Canada. So he's here today with us to speak about how helpful it has been that these programs were offered through video conferencing platforms. So over to you, Haas, welcome.
Thank you, Christina, for the introduction. So hello, everybody. My name is Haas Mawji. So hi, everyone. Thank you for joining us today. My name is Haas, and I had a stroke in 2015. It's been quite a journey to where I am today. Thank you to Heart and Stroke and March of Dimes Canada for inviting me here to share my experience. I'd like to start by telling you more about my stroke. Slide 2. That day I was on a video call with a friend and she noticed I was speaking strangely. I looked at my image in the video and my face was drooping on one side. I told her that I would call her back. I went to stand up and suddenly fell back down. I realized that my right side was paralyzed and I had to act fast. I slid down the edge of my bed on the floor. Then I crawled to the door. I grabbed the door handle, but my hand slipped. I tried again, and this time I managed to open it. I shouted to my family to call 911. At the hospital, they told me that I had a stroke. I couldn't stand as my whole right side wasn't working in February 2015. I started therapy in the hospital and was there for 6 weeks. I was discharged home and attended outpatient therapy for 3 months. I even did water-based therapy, aqua therapy, which was great. I continued to practice my walking, and it took me about 2 years to be confident. I still take a cane with me for support. Slide 3. In 2016, I started volunteering in the stroke ward at Mackenzie Health. I spoke with stroke survivors and shared my own experiences. The patients were inspirational and we learned from each other. I also attended March of Dimes Canada Employment Services workshops. I started providing peer support in Richmond Hill with a support group on the first Tuesday of each month. I'd go in person where there were just 5 to 6 people attending. Then the pandemic happened and everything started to go online. Slide 4. Since the stroke, I've been interested in improving my computer skills and I had been taking classes. When we stopped for spring break, we never went back in person. So I continued to update my skills at home and started looking for other things to do online. I Googled webinars and found the March of Dimes Canada webinars, peer support groups and aphasia connect groups. I also attended mental health seminars through the Center for Addiction and Mental Health. Slide 6. I started going to the After Stroke Tuesday conversation group regularly on Zoom, over Zoom. I also found the virtual aphasia peer connect group, which was helpful for me to continue to work on my communication skills because we couldn't meet in person. I try to walk as much as I can, especially when the weather is okay. Successes. The virtual programs have been amazing. It's nice to go in person too, but you end up only meeting people who live in the same area. When it's online, you can meet people from across Canada, from Nova Scotia to St. John's to Edmonton to Vancouver. I've met so many people and learned so much. The conversation group has really grown. They have started using breakout rooms. The smaller groups allow everyone to have a chance to speak and share their stories and ideas if they are comfortable. Slide 7. Sometimes there are different topics or guest speakers, and then we break off into smaller groups to discuss in each room. There are now about 70 people who attend the weekly Tuesday virtual conversation group. You can also share resources. The After Stroke staff take notes and send links to those resources that were discussed or shared. You learn a lot. I hope the virtual programs stay even when we can meet in person again. Challenges. There are some challenges with using virtual platforms. Many hospitals temporarily stopped the in-hospital peer visiting program because it was too difficult to do virtually. A lot of people have trouble with video conferencing. Some people like face-to-face or in person better. Not everyone is tech savvy. Some people have a hard time connecting with Zoom. When we use breakout rooms with video conferencing, everyone should be given a chance to talk. It's helpful to have someone leading the group and making sure that everyone has the chance to speak if they want to. With virtual, it can be difficult to get the help you need right away. For instance, when learning Excel online like I am, sometimes you have trouble. You can video conference with your teacher for help. Here are a few things I want to share my experiences using virtual platforms. So slide 8. Number 1, life is not just about improving my skills for me. It's about continuing to do normal activities, but now doing them a virtual way. The pandemic has changed how we do things, and there are few ways to get the support we need. Number 2, given the virtual programs at March of Dimes Canada a try. They bring people together. Everyone can share in a conversation and learn from each other. Slide 9. You may need help to try out a virtual program. Don't worry. there are after-stroke coordinators who can help you and your family to set things up for you, like phone, a tablet, or computer. Number 4, I hope those virtual programs are here to stay, especially for those individuals who live in remote locations. Thank you to those organizations who have offered their services in a different way and respond so quickly to help persons with stroke. If you want more information about after-stroke programs, there is a link provided on the slide. Thank you very much. Thank you.
Thank you very much, Haas. That was excellent, and your points, your takeaway points are very good and very helpful for everybody else listening. Hopefully everyone got those down. You know, that experience that you've gone through and how you've been able to adapt and find new ways to be engaged is really terrific, and I think a good lesson for everyone. I now have the pleasure of turning it over to Dr. Anita Mountain. Dr. Mountain is going to look at the rehabilitation aspects of stroke care and how that has been impacted, and some tips and strategies in our new virtual world. Over to you, Anita, and just give me 1 minute to give you control.
Great. Thank you, Dr. Lindsay, and I'd like to thank the organizers of this Stroke Month joint webinar for inviting me to be a presenter speaking about this very important topic. And also to Haas, thanks for sharing your experience. It certainly highlights some of the many challenges as well as benefits of virtual programming during this time. So I thought I'd start with the definition of virtual care, and I really like this one proposed by Heart and Stroke because it hits all the important aspects of virtual care. That is that it's a healthcare encounter between a healthcare provider and person, each in a different location. And of course, it may also include family, caregivers, other members of the healthcare team, which may or may not be in the same location of either of the two aforementioned people. And it can include, it uses technology to connect, that's key, which can include a variety of modalities such as phone, computer, video conferencing, and it can be very high tech, thinking of, the advanced teleconferencing suites that are sometimes present in institutions, or very low tech, such as 2 landlines. And I just wanted to highlight 2 terms that are sometimes confusing in virtual care, and that's synchronous and asynchronous. So synchronous means virtual care that's happening in real time. So for instance, a phone call or video conferencing. While in asynchronous care, there's no real-time interaction. So for instance, forwarding an exercise journal that has blood pressure, heart rate, perceived rate of exertion to a healthcare practitioner for review and for them to be able to respond to at a different time. Let's see, I can advance the slides here. Oh, good. All right. So virtual care can be delivered using different modalities and for different types of interactions. And this graphic, which is taken from the Nova Scotia Virtual Actual Care Plan, outlines some possible examples of synchronous and asynchronous care, ranging from such things as virtual video conferencing for direct patient care, to case conferencing between professionals involved in a patient care, to different types of portals where information and results can be uploaded by the provider or the patient for each other review, amongst other. And the goal, of course, of virtual care is to enhance the care by providing a personalized approach to enhance access to care therapies in a manner that is safe, effective, high quality, and provided in conjunction with in-person care. Let's see. Great. And when we apply virtual care to the stroke, there are opportunities to enhance care throughout the entire continuum. But today, the portion of the continuum that I'll be focusing on is rehabilitation. And virtual care in rehab is actually not a new concept. And it's more traditionally been referred to as telerehabilitation. And in fact, when I did a simple PubMed search, the first paper with the term in the title was using telerehabilitation to support assistive technology. And it was published back in 1999. And in that paper, they acknowledged that the origin of the term telerehabilitation is actually unknown, but their working definition was the use of telecommunications technology to provide rehabilitation and long-term support to people with disabilities. And in their paper, they describe a program to provide follow-up care using what was referred to as a low-cost video telephones. And you can see an example of the diagram from that citation. And these low-cost video telephones transmitted simultaneous video as well as audio over standard telephone lines, which apparently were only widely available at that time because of a 1997 international video conferencing standard that helped to standardize the equipment related to transmission of data rates over standard telephone lines. And in this paper, they describe the use of this technology to provide assessments such as seating assessment, augmentative communication, computer access, as well as to use it for home modification evaluations. And they highlight many of the potential benefits of that technology at that time, such as improved access and accessibility of services delivered that way, but also identified several potential challenges, such as ease and use of access of the technology, privacy issues, funding issues, licensure and competency issues, as well as the loss of what they refer to as the human factor of in-person care. And those are interestingly all still similar challenges that can be identified today. And again, when I did a simple search on the terms telerehabilitation and stroke, the first references start to appear in the early 2000s with a steady, slow addition to the literature that then picks up around 2018, so sort of right pre-pandemic, but then even more so accelerated in the past year or so. And when I search virtual care and rehabilitation, you can see that that's a newer term, and that the rising number of citations are mirroring that of telerehabilitation in the last couple of years. And when I reflected on my practice, I was doing approximately maybe 10% of my outpatient visits pre-pandemic virtually, which for me was largely myself or perhaps other members of the healthcare and rehab team in a teleconference room here at the Nova Scotia Rehabilitation Centre in Halifax, where I work. And the patient, plus or minus family, caregivers, members of their local rehab team at their local hospital in their local telehealth room. And of course, when I look at the sort of the variation in my percentages of the visits over time, it very closely mirrors, and by no coincidence, mirrors the institutional guidance for in-person versus virtual care necessitated by the COVID waves, which are underlined there for Nova Scotia. And now when I see someone virtually, it's usually me using a video conferencing program with me in my office like I am now, and the patient at home or at other private locations. And it's really interesting, the opportunities that seeing a patient at home provides. I was an occupational therapist before I was a physiatrist, and I still really value and feel privileged to have the opportunity to see someone in their everyday home environment. The actual steps they need to climb, the exercise equipment that they're using, their calendar or book for keeping track of appointments, which often is more or less organized than would be described if they were in my office in the clinic. And just the human connection of being able to see pets and gardens. And I've been taken on so many virtual tours of homes, not only to see environmental obstacles or barriers, but also to have the opportunity to see things that are important to the person and value to them, as well as really innovative solutions to practical problems that have been encountered at home. And sometimes there are interesting clinical observations to be made as well, seeing someone in a potentially distracting environment such as home versus in a calm, quiet clinic environment. And where others in my division and my organization had been advocating for more flexible options for virtual care prior to the pandemic, particularly with such a wide distribution of rural population in Nova Scotia, the impetus for driving these healthcare system changes were not present until the pandemic really limited our ability to provide in-person rehab and care to our patients. But now we need to step back and be really intentional in developing the proper infrastructure, processes, and policies within our programs and organizations to make sure virtual care is delivered in an equitable, accessible, evidence-based manner with processes in place for measuring outcomes, program evaluation, and of course, continuous quality improvement. And now that we have the ability to provide virtual care, the future is likely that permanent transition to a hybrid model where we can provide virtual care and in-person care depending on what's most appropriate. And in order to provide some structure and guidance to this transition, Heart and Stroke, led by Dr. Lindsay, have developed a framework that incorporates 5 core elements of virtual care to consider when planning and integrating and implementing virtual care. And these 5 elements are the system and the environment, so the broader context with organization, clinical teams, individuals, and communities operate from a higher level perspective of leadership, quality, social determinants of health, funding policies, etc. The organization, so the level of the hospitals, clinics, the infrastructure, and human resources, etc., that are required to actually deliver the virtual care. And then, of course, there's the actual clinical care delivery. So you must consider such things as capacity and competency of clinicians to provide that care and make sure that you're using the best evidence and guidelines for that. And then, of course, there's the issue of technology. And so looking at things such as access to and affordability of technology, along with privacy and security issues. And at the center of all of this, most importantly, is that individual recipient of care and their family and support and their communities. And so we really need to make sure that we're looking at things such as access, equity, cultural sensitivities, patient capacity, complexity, urgency, and safety, and all those things must be considered when designing our programs. And so when deciding, whether or not the goals of a session should be delivered in person or virtually, there's also a virtual care decision pathway to help make sure all the important elements have been considered for that individual care encounter. So first, you must assess your readiness. So really considering the state of all the elements that I mentioned on the previous slide. Is there anything that's a must that is not present, such as, for instance, mitigation of privacy and security issues as an organization? Next, you must consider the initial triage. So essentially, can the purpose and intent of the encounter be met virtually? So for example, if we consider asbestos demanagement, one of the treatment options is botulinum toxin injections. And so clearly that would require an in-person visit to do that procedure. But if, for example, the injections are being done to help open and decrease pain in, say, a clenched fist, then perhaps a follow-up visit can be done virtually, using a video conferencing option, being able to look at the patient or the caregiver or family opening the hand and see if they're able to, provide that care with less pain. And perhaps if objective measures of range of motion are required, working in conjunction with the local OT. So next, appropriateness should be considered. So once you decide the goals of the visit could be met virtually, you must decide whether it should be based on other consideration of other factors. So in the last example, decided virtual care could be provided for the follow-up visit, but perhaps it's not actually an option because the person doesn't have access to reliable internet or a device capable of video conferencing. Other elements to consider under appropriateness would be such things as the cognitive or communication or physical abilities of a person, as well as the urgency and complexity of the issue that you're addressing. Next, and all these things I should mention, you kind of do it together. It's not sort of that linear thing, but another consideration would be safety and risk. And so, really thinking whether or not there's any issues that need to be mitigated. And if there are, is there a way to mitigate a potential safety issue? For example, having a caregiver or a family member present at the visit may allow you to do a therapy that you wouldn't be able to do if they didn't have a support person. Or a public health risk like the pandemic, the risks may outweigh the benefits of seeing someone in person, even if that's the preferred method given all other options. And finally, you'd have to consider what technology, what modality will best meet yours and your patient's needs when providing virtual care. And of course, just like any other program, it's really important to build in continuous evaluation and feedback, considering such things as whether or not the encounter did in fact meet the purpose and goals of the visit. Was it successful? Were there any unexpected issues or benefits that arised? And was the patient and clinician satisfied? I can't tell you how many times I'm doing video conferencing, but then I convert back to a setup similar to what I showed you, where I'm seeing the person video, but we convert to a landline or cell phone for audio, for instance. And just one additional and very practical and comprehensive resource for virtual care that I encourage you all to check out is a virtual healthcare implementation toolkit, which outlines many practical how-tos of delivering virtual care with such things as tips for patients and clinicians, safety and privacy considerations, and evaluation structures. And it does have a specific section on stroke rehabilitation as well, which is nice. And of course, as we move forward, as I move forward on my slides, there we go, it's essential that the care we deliver is rooted in the best evidence and best practice. And recently, the Rehab and Recovery Working Group, led by Dr. Nancy Selbach and Jennifer Yeho, reviewed the rehab literature on virtual care, and an update to the Canadian Stroke Best Practices Rehab and Recovery module will be coming soon. And although we know that virtual care can be an effective method to deliver rehab, there's still a lot of work to do to validate specific, for example, virtual assessments and treatment modalities, and to understand who and under what circumstances a virtual or hybrid model is the most effective method to deliver care. And for instance, what are the sex and gender and literacy and diversity and cultural and geographic and access issues that need to be considered when providing rehabilitation through virtual care? And just as I end my portion of the webinar, I just want to leave you with 3 key messages. Number 1, that virtual care in rehab has been greatly accelerated by the pandemic. Number 2, that proper systems, processing, training, technology, and infrastructure are required to allow equitable and appropriate delivery and access to virtual care across Canada. And number 3, that virtual care has many potential benefits, and while it can complement in-person rehabilitation, it does not replace it. Thank you.
Thank you so much, Dr. Mountain, for sharing your insights. I found it very interesting to learn that telerehab started in the late 1990s, and it's taken a pandemic to truly allow us to recognize the value of it for providing care to our patients. So thank you for providing those insights, as well as how to evaluate whether or not virtual care is the best option and whether it's helpful for a client or not. So thank you so much. That was wonderful. I appreciate it. Next, we'd like to introduce Dr. Michelle L.A. Nelson. Dr. Nelson is a scientist in the Lunenfeld-Tanenbaum Research Institute at Sinai Health System in Toronto, as well as an assistant professor in the Institute of Health Policy Management and Evaluation at the University of Toronto. Michelle leads an international research teams focused on rehabilitation and community reintegration for people with complex care needs, with a particular interest in the role and contributions of volunteers in the voluntary sector in integrating care transitions from from hospital to home and intersectoral collaboration. In 2020, Michelle was appointed the inaugural Chief Knowledge and Innovation Officer for March of Dimes Canada. Having leadership roles in both research and practice environments creates an opportunity for practice-informed research and leverages those insights to advance the design and implementation of evidence-informed transitions and community reintegration services. Michelle will be speaking about virtual programming in the community setting. Over to you, Michelle.
Michelle, you'll now have mouse control.
Perfect. Thank you so much. Hello, everyone. Lovely to have some virtual time with you to talk about virtual programming across the stroke pathway. I'm just going to make sure that I can advance my slides. Not yet, it's delayed. While we wait for the slides to catch up, maybe I will start by acknowledging and thanking the contributions of Haas and Dr. Mountain in the previous. It'll actually expedite some of my slides because I can refer to their excellent content. So it's lovely to follow your presentations. Patty, the slides are not advancing yet, even though I can see my mouse.
Okay, I'll just play Vanna White for you.
Thank you so very much. So as Christina noted, I'm to talk to you today about virtual community-based stroke services, which I thought was a bit of a misnomer. Which is why I put it in little quotes for you. One of the things I wanted to note was that we often, when we talk about community support services, we refer to this diagram because we particularly enjoy, from a non-profit or community-based perspective, that community-based programs has its own separate bubble in the bottom in the community management and reintegration. And I thought before we talked about virtual community-based, maybe I would just do a quick take advantage of the moment and do a quick discussion around community-based services. And we know that effective stroke management includes care provided across the pathway from hospital to home and community, and that the supports and services provided by community organizations is essential. Through a variety of stakeholder engagements, we've heard that community is both a destination and a partner. So we'll often talk about referrals to community or the opportunity to leverage community-based assets. And last year or 2 years ago, a team member at one of the Stroke Congress meetings said that services really community to them was services closer to where they work, play, or sleep in your own bed. And that's really struck me. Thinking about the heterogeneity of community-based programs, and I talk about third sector. Third sector organizations are community-based organizations that are informal or formal, voluntary or professional, not-for-profit or charitable, but are generally autonomous, non-government autonomous agencies. Thanks, Patty. So I would be remiss if I didn't take an opportunity to talk about partnerships between third sector organizations and health systems, and that third sector are considered to be a key system stakeholder. We know that third sector organizations provide valuable health and social services to individuals impacted by stroke, but one of the key points to make is that these organizations are yet undervalued, understudied, or underrecognized within health systems and services. And so I'm going to talk to you about some of the lessons from COVID that may actually help us shift that. I've given you a Goree quote that notes that with training, support, and capacity, savings to healthcare systems could be realized with a shift away from institutional models. And so one of the things I think COVID has presented is an opportunity to think about how third sector organizations can support a continuity of care across the stroke pathway, so from hospital to home and community. Next slide, please. I really like the image that came out of Gartner late last year, talking about a reset across business and social services. And I thought it was a nice way to think about the implications of COVID in community-based programming. At the very beginning, it's hard to believe it's been 15 months, but at the beginning, when many of the community-based services were actually put a halt to, we saw a kind of pullback of staff and volunteers. The immediate action was to keep people safe, and we saw programs and services delayed, stopped, or put actually on hiatus until we could figure out how in community settings to deploy services in a way that still maintained safety and security during the height of COVID. What was interesting at this time was, although organizations with formal volunteers and staff roles, what we actually saw was a rise in mutual aid. So the idea of community-based programs or community-based assets actually leveraging to rallying to support members of their community. And so there's been an interesting point of study around the rise of community response in parallel to community-based organizations or more formal programs. What we quickly saw, though, in the community-based sector, in the third sector, was a rapid pivot of essential programs and services that clients or staff deemed essential. And what we saw were those programs were immediately pivoted to online platforms. And often those programs were using, as has noted, Zoom or Teams or existing Google Hangouts. And what was interesting was, as that was happening, there were discussions about whether or not those programs and those platforms were actually meeting the needs of the clients who would have typically taken advantage of or participated in face-to-face programs. At the same time, there were lots of questions about the fidelity of the intervention. If you move an intervention from face-to-face to online, is it deriving the same outcomes? And so I'm excited to see the update to the guidelines related to the virtual delivery. And I know that Dr. Salbach has a trial looking at a virtual program, of exercise program. So those results will help community-based organizations meet the needs. In that middle point, in that recover phase, what was interesting was as more programs came online, and if you actually look at a variety of local community organizations, you'll see that they've provided lists of programs and services that have pivoted to virtual platforms. There was actually the need to develop some ancillary or support programs. So the programs would actually have some, organizations would have stroke support focused, but then there would actually be access to technology or how to engage in online environments or helping people actually gain access to technology so they could take part in programs. So that was a really interesting, it was really an interesting evolution. And so now we're in this place, and that's why I'm so keen to have this conversation with you all, that we're actually in a place where we're actually renewing. So we're learning from lessons, we're taking forward, and we're actually building out the virtual program platforms for the future. So then, there's a question of, so what did you learn? In that renew phase, you're supposed to use the learning. So what did we learn? Next slide, please. So has identified a few, and we've learned a lot in 15 months. Some of them we've identified the questions, we don't necessarily have the answers, and we're looking forward to developing some best practices. The idea around having to adapt programs. So the process of what were the essential elements of an intervention that could move to an online mechanism? What is the right technology for the program? Community-based organizations have a wide array of programs and services at their disposal, but whether or not they had the ability to train staff and actually recruit and support people in participating was a challenge that we saw across the sector. As has noted, the idea about access to technology. So we saw both an increase in utilization. Interestingly, through March of Dimes programs and services, we actually saw some people did not transition from face-to-face to virtual, but we actually saw a rise in new clients, that people, by virtue of being able to access through technology, we were extending the reach. And so we do have programs and services that actually have clients who are participating from across the country. And as Has noted, that people report being very pleased and excited about the opportunity to connect with their peers and colleagues from across the country. We noted, though, that there was an opportunity to build in social interaction time. One of the values of face-to-face that people reported was, in fact, the time spent together in addition to the actual activity, which raises questions about how to build rapport, particularly in group settings, and that there are privacy considerations that community-based organizations need to think about, particularly when we think about the types of programs and services that are being provided. Many people talked about the convenience of not having to drive, pay for parking, adjust schedules to attend programs. And at the same time, we heard people talk about Zoom fatigue and the idea that this form of interaction is not, it doesn't feel natural. And so there is a whole form of Zoom skills that people need to develop. And then, of course, in as much as we, even in this session, talk about how do we actually adjust for technology fails. So those were some of the key lessons. But as Has noted in his earlier talk, technology, the virtual programs aren't going away, and that many of our clients have actually indicated that they expect a hybrid. They prefer the opportunity to decide and determine what's face-to-face and what they would participate through virtual means. So if it's not going away, what are some of the needs and considerations for the future? Next slide, please, Patty. So consideration number one, the idea around community-based organization, relevant or specific evidence and guidance. The virtual healthcare implementation toolkit, very useful, requires an opportunity for us to think about what does that mean when we transition to community-based programs and services. And so thinking about a potential add-on or overlay to that for community-based stroke support services would be particularly helpful. The Betker and Resnick late last year published a key questions and considerations for ongoing evaluation of virtual programs and services. And the framework is is very helpful when we think about what are the evaluation key questions, the perspectives that we would want to gain those perspectives from. So it was published in Physical Therapy late last year. But really what we need to do is think about what future research questions could inform community-based services. Next slide, please. Consideration number 2, the idea about attending to the idea of access and equity. We know that, and as Dr. Mountain noted in her talk, that people came into COVID with various access and equity considerations, and that COVID has either revealed, amplified, or exposed those inequities in our social fabric. So the idea through this consideration is to think about access to technology as a mitigation, in addition to acknowledging that access to technology is in fact another source of inequity. We had done a survey at March of Dimes of 1,000 people with disabilities across the country, and 75% of those individuals said that access to technology is part of the leveling the playing field. But, and there was a big caveat, but having to derive access or obtain the technology for programs was a key issue, whether it be cost, access, the ability to use it. So it's not sufficient for us to say that access to technology is going to reduce inequity. We need to think about how the technology and the use of technology may in fact be amplifying inequity. There is an argument that third sector organizations can actually ameliorate barriers to or inequity. And if you think about how community-based organizations are typically formed, they usually are derived by and with and for people who live in communities. So thinking that they are built upon the premise of access, equity, inclusivity, driven by the unique needs and perspectives of community members, it would be a logical flow to think that community-based organizations are well positioned. However, this brings me to consideration number 3. We need to be thinking about, next slide, please, Patty. We need to be thinking about the health of our third sector. And Imagine Canada released early this year in February, I've given you the link. I've released a snapshot of what's happening in the third sector. So if we are wanting to rely on third sector organizations or community-based organizations to support stroke survivors and their families, we need to think about whether or not those organizations are actually going to be there. In the report, they highlight, Imagine Canada highlights that needs are often exceeding capacity, that with COVID, programs and services have pivoted to virtual, but we're also seeing a decrease in staff and volunteers in those services, and that there's actually a decrease in resources available to provide or to actually underpin those programs. So if we actually want those organizations to be available to support stroke survivors in their communities, we need to be aware of what's happening in the sector. This is particularly important when we think about that grassroots community-driven response. Right now, what's happening in the sector is large organizations are having the ability to sustain and potentially innovate, and small local organizations are really struggling. And that's particularly reflected in the leisure, recreation, social service sector of the charitable sector. So it really behooves us to think about what is the health of the sector that we are relying on as a key member of the stroke pathway, and their capacity and ability to provide services in a virtual means. So that's a fairly whistle-stop tour of community-based organizations' involvement in, but just some key takeaways for you. Next slide, please. So COVID has expedited the transition of community-based programs to virtual. Clients are, as Has noted, and is consistently across our client base, People are extremely satisfied. They're reporting, however, challenges with technology, but they want to maintain a hybrid model, which will be particularly helpful when we think about response to in the various stages of reopening across the country. We need to be able to adapt and provide hybrid perspectives. We need to be thinking about how to take what we've learned over the last 15 months and use it as an opportunity. And then, of course, I wouldn't be advocating if I were here if I didn't ask for implementation and evidence specific to third sector organizations' program design. So thank you so very much for your time this morning or this afternoon, wherever you are in the country. And thank you to the organizers for inviting me to speak.
Great, thank you so much, Michelle. That has been fantastic. Really, really sound knowledge. I really like, the models you put up at the beginning and the way we need to start rethinking about what community is and how we service and resource it accordingly. I think there's so many lessons to be learned there. We have many questions, which is awesome. Thank you, everybody, for being so engaged in putting questions up for us. So we will turn this over to our speakers, and I'm going to start directing the questions to them. Let's start with Haas. Haas, can we ask you the first question? In your experiences and all that you've kind of encountered over the last year, what do you think's been the best part of the virtual programs, the ones you've attended at March of Dimes or elsewhere? What has been the biggest takeaway for you?
Well, the biggest takeaway was when of the conversation group and the aphasia group, like we're meeting people from, like I said in my earlier, across Canada, we're meeting a lot of people, and we're learning a lot of different things from other individuals. Like if there's something not what do you call it, if something that the individual in Alberta's doing, they're saying for the other persons that you can try this and all that, right? So when you are meeting all these different people, you're learning different things. So that's what I like about this virtual, is you're meeting different people and learning a lot of things. And before that, before I joined, I was taking like classes and computers. So I got to learn more about technology, which I didn't know a lot of. And then when we're getting onto these conversation groups or aphasia groups or any group, so I learned a lot, right? So it's just about meeting the people in our March of Dimes conversation groups.
That's fantastic, Haas. It sounds just wonderful to be able to meet all those people across the country, and you wouldn't have necessarily had that before without virtual programming. So thank you. Yeah, that's wonderful. Dr. Mountain, I'm going to kind of ask you a similar question. What's been the biggest advantage to you in your practice? I know you alluded to it in your discussion, but if you could pick one thing that's really been highlighted for you, what would you say it is?
That's a good question. I think that probably the biggest benefit has been the availability of offering that option to people. It's for some people, it's very hard for them, either mobility wise, or perhaps they're dealing with post-stroke fatigue, and to get up, get ready, come to an appointment can be really quite taxing in and of itself. So having the opportunity, I think, to see people in their own environment, highlighting the things that are most challenging to them, or perhaps, being able to see more successes in that environment. So I think that's probably been the biggest benefit to me, is having the ability to offer that option to people more readily, and also that ability to see them they're really in their own home environment, in their own setting.
That's great. Thank you. Thank you. Patty, is there another question?
There's lots. Okay. Here's an issue that everybody's been facing in virtual care, and it does speak to the issue of equity in access. Many of our Canada's, made up of so many different nationalities, ethnic cultures, and not everybody has English as their first language, but they all are entitled to equal care across Canada. What has been the challenges and what are some of the solutions that have been seen with virtual care for people who require translation? And I'll start with Anita. Does this automatically mean somebody has to come in, or how have we been dealing with the need for translation using virtual modality?
Yeah, so that's interesting, and I'm sure you know, different organizations or institutions have different ways of dealing with that. You know, certainly in the institution I work at, Nova Scotia Health, we have access to translators either via phone or via video. Via video, you have to be in person, and it's really an effective way to enhance things, but obviously that's an in-person visit to use the video. But we do have access to translators over the telephone, so being able to use the telephone as one of the modalities to have a translator in on your virtual visit is an option. You know, sometimes people will use family members, but obviously, you know, sometimes that's not an option, and in fact, you know, there's some benefit to having a third-party translator as well. So that's how we would deal with it here, and I would think that many of the healthcare institutions across Canada have that same option.
Dr. Nelson, I'm interested to hear about that issue or that situation in the community setting. Is there as much access to those types of services in the community setting for the organizations that are providing programs and services?
It's a really interesting question, and you know, within the community setting, I think there's actually there's probably a pro and a challenge. I think what we're probably seeing is decreased access to some of the more mainstream large organization, large programs by virtue of needing to communicate potentially within you know, a small set of languages. But what it actually sparks for me is probably the opportunity through virtual programs, and going back to Haas's comment about nationalization of programs, is that it may actually increase the opportunity to engage with stroke survivors who share particular cultural and language considerations, where maybe in a smaller community they may not have had access to members of a language sharing or culture sharing group. Virtual may in fact increase the ability for those individuals to receive or access peers. I have a colleague, Dr. Hardeep Singh, who's particularly interested in equity considerations. I think she's probably on the call, but if not, I'm going to flag this question for her as well.
Great, thank you very much. We're almost out of time, so I'm going to ask one more question. And I want all three of you to answer this in turn, and we'll start with you, Haas. You know, what we've heard is that we want virtual care to stay as part of our healthcare system going forward, to be part of the option. So what can we do as healthcare professionals, stroke survivors, researchers to advocate and to ensure that virtual care is here to stay? So from each of your vantage points, where are the opportunities and where should we all be focusing? Haas, can we start with you?
Well, that's a good question. That question I would have to think about. I don't know offhand. So can I pass it over to one of the ladies, like as Dr. Nelson, maybe?
And then what I will do is maybe comment and with you, Haas. We've had people like you. I think what you're doing right now is step one. The fact that you're here and speaking about the virtual programs and what that has meant to you in your recovery. And, you know, I think getting more patients to speak about the value and how important it is to them may be one way to start. And you're already doing that, like by being here today and talking about how positive that's been for you and how necessary. And I think we encourage all people with lived experience to speak up their voices. Dr. Nelson, would you like to comment next?
Yeah, thank you. Yes, Haas, thank you for that comment. I think that is, and Dr. Lindsay, thank you, because I think that is the point. You know, we need to actually reflect the value of virtual programs for people who are using them, accessing them. And then at the same time, we need to match and marry that with evidence of outcomes and reducing inequity And that's, I think, knowing how policymakers make decisions, I think we need to generate the evidence and to confirm for them that virtual is effective and efficient.
Dr. Mountain, would you like to finish up and then we'll wrap?
Yeah, certainly. I mean, I don't think I could say it better than Dr. Nelson did, just the importance of making sure that we have the evidence to underpin the care that we're providing. And I think, you know, as clinicians, really, you know, talking to our administrator, our systems leaders within our organization is very important. You know, we have the unique opportunity of being some of us being frontline healthcare providers, as well as, you know, in some of the leadership positions. So, you know, hearing the experiences of people with lived experience, and certainly, you know, every time I'm talking to a patient who is taking advantage of virtual programs, they're always, you know, saying, I hope this doesn't go away when the pandemic goes away, so to speak, because really just that opportunity to provide, to amplify the effect of our programs, to decentralize our care from you know, from cities and larger population areas to reach out to more rural areas, I think is so important, and it helps to really provide, you know, that access of care and programming to people who otherwise wouldn't have that opportunity to achieve that. But then, of course, as Dr. Nelson said, really making sure that we're stepping back and making sure that the care we're providing is rooted in best evidence and practice, and encouraging the research and participating in the research to find out what that evidence is, I think is very important.
Obvious. So thank you. So, you know, the key messages are we need the patient voice. We need people who need services, and where virtual care may be the only way for them, or a much more convenient and appropriate way to voice that. And then we need evidence and the research, and we need to continue to work with our health system leaders at the government, you know, provincial and federal level to ensure that it stays. So on behalf of our partners, March of Dimes, and ourselves at Heart and Stroke, we'd love to thank everybody. Thank you, Rebecca, for all of your organization, Rebecca McGuff behind the scenes here. Thank you to the teams for putting this together, Suzanne Smith-Bailey as well, who's worked really hard with Rebecca. We want to acknowledge our sponsors, Pfizer and HLS Therapeutics, for allowing our webinar series to happen. And we wish you all well. Summer is coming, so hopefully your bubbles will open up a bit and people can finally be reunited with families. Stay strong. We're here for you. Please reach out to us. All of the resources we talked about are available at the Canadian Stroke Best Practices website, strokebestpractices.ca, and on the March of Dimes websites. So please seek us out. We are here for you, and we wish everybody well. Thank you very much.
Thank you very much, everyone.
Thank you.